Hello ladies and gentlemen, today I want to talk to you about a very simple to apply test to test the actual strength and capabilities of the supraspinatus, which is actually one of the 4 rotator cuff muscles. The rotator cuff is primarily responsible for stabilisation of the shoulder capsule and also movement as well. Now, the reason I want to look at the supraspinatus today is because it's the only muscle of the rotator cuff that actually lies superior to the scapula. So it lies on the top in terms of the scapular border. Now, because it's in that position, it's actually most susceptible to impingement injury or tendinopathy. If you don't know what impingement or tendinopathy actually is, well, impingement is where the tendon of the actual muscle itself can catch, if you like, on the bones. So whenever there's movement, there can be sort of catching on the tendons of the muscle itself, which can be very, very painful. So that's why I want to have a look at the supraspinatus today. From what I'd recommend is actually, before you watch this video, I'd actually recommend checking out the supraspinatus in a bit more detail, whether it's from a website or another YouTube video, just so you get a better gauge of the actual anatomy of the supraspinatus, where it is, what it does. But for today's video, all we really want to know, or all we really need to know, is that the supraspinatus lies superior to the scapula, so within the scapular border, and it attaches to the humerus. So it's mainly responsible for, like I said, constricting the shoulder area itself, the shoulder joint, the shoulder capsule, and also allowing slight amounts of abduction as well. So like I said, tendinopathy and impingement tends to be the main sort of problems with the supraspinatus. This is due to, especially in my experience, meeting a lot of patients and clients that tend to come to me and they, with a little bit of delving, they tend to do a lot of overhead movements. So you get clients that tend to do a lot of lat pull down movements, shoulder presses, bench presses, where it's going to create a bit of a rubbing effect on this particular muscle and therefore an impingement. So what we're going to do today is a very, very simple test, just to make sure we can actually understand whether there's any pain or weakness within the supraspinatus. I'm going to call the test the supraspinatus strength test, but you might have heard of it as either the Job's test, scapation test. You might have also heard of it as the empty or full can test. So they're the common names for this. So what I'm going to do now is I'm going to ask my partner Alexi just to come here, and we're going to show you how to do this very simple test. So hi Alexi.
Hello.
So all I'm going to do is I'm going to be asking Alexi just to stand oblique to the camera. Now the reason I'm going to get her in this position is just so you can get a good gauge of what actually happens here. In a second I'm going to be asking Alexi not to go into the frontal plane, which is this T shape here, but I'm actually going to get her into this scapular plane. So I'm going to raise up Alexi's arm here. So this will be the frontal plane, and I'm only going to test the right hand side on this test. I'm going to move and migrate the arm about 30 to 45 degrees from that frontal plane here into this scapular plane. Now the reason I'm going to put Alexi into this scapular plane is for 2 reasons. First of all, it actually places the humerus into the same mechanical axis as the scapula. So that's going to give us a true indication of the actual movement. Second of all, when I actually place Alexi in this position, there's going to be no appreciable humeral rotation. So having it in this position is actually going to get the least sort of co-activation from other muscles that help that abduction or the flexion as well. So Alexi, I'm just going to ask you to stand with a slightly more stable base, so we can either do this standing stable on the floor or seated on the edge of a seat. And what I'm going to ask Alexi to do is just go into an internal rotation here with the thumb pointing down towards the floor. So in this scapular plane, Alexi, if you just look straight ahead, all I'm going to actually do here as the clinician is I'm going to stand side on, and I'm going to support and stabilise the scapula here. And with my right hand, I'm just going to press down and offer a slight manual resistance. And there's 2 things I'm going to discover here really. First of all, if there's any weakness, so to see if there's any possible neurogenic problem, and second of all, to see if there's any pain at all. So Alexi, on a scale of 1 to 10, do you actually feel any pain?
0, no pain at all.
No pain at all. Okay, so I'm going to ask you to go into external rotation now, look straight ahead, and I'm going to do exactly the same thing. So there's no obvious weakness here. Any pain on this one?
None at all.
Good stuff. Okay, just relax for a second, Lexi. So gauging pain is going to be quite subjective. So you might actually have a client that's inexperienced of understanding what our scale of 1 to 10 is in terms of pain. So what you could actually do, if we assume that Alexi's left hand side is an unaffected area, we could maybe test the unaffected area to get a good gauge of whether there's going to be a problem on this right hand side here. So it is going to be subjective mainly, but we can get some sort of gauge, and if I get anything maybe above a 4 out of 10 in terms of pain, then we can sort of ascertain that there's going to be some sort of moderate pain with the supraspinatus. The main things we really want to work out here is whether there's going to be pain which could be a problem with the tendinopathy, like I said, or the impingement, or there could be a weakness which, like I said, could be a neurogenic or a nerve problem, or there could be both or none at all. So one thing that actually is quite conflicting regarding this test is you might have noticed I actually took my client into a 90-degree position here. Some research has actually suggested that most supraspinatus activation happens between 15 to 30 degrees here of shoulder abduction and flexion. Now, if I actually do the test in this position like so, this research does suggest that the supraspinatus is more truly actually being tested here. However, other researchers also suggested that if I were to actually anaesthetise the supraspinatus, the deltoids are actually still responsible for going into full abduction and flexion here. So there's conflicting research regarding the actual agonist or synergistic capability of the supraspinatus. But one thing which has been very consistent regarding research is no matter where we actually take the test from, whether it's from 15 degrees, 30 degrees or 90 degrees, is that supraspinatus, when actually anaesthetised, clients have been unable to actually hold this position here isometrically for about a minute or so. That tends to be the upper limit. So what we do really know about supraspinatus is that it's actually a really key muscle with regards to isometric contraction. So even though we're not quite sure about its movement capabilities or what phase the movement capabilities actually occur, we do know that it's extremely important, as I said, in terms of stabilisation of the shoulder capsule and therefore isometric contraction. So Alexia, I'm just going to take your arm down now, and thank you very much. Thank you.
Thanks.
So, luckily with Alexi, she's extremely fit and she's very lucky in that she's not really suffered from any injury here. So four things could actually happen really in terms of our outcomes. First of all, it could be like Alexi, where there's no discernible pain and no obvious weakness at all. So she was able to actually resist my force I was applying. That's going to be a good sign. Second thing is where there's no weakness, so the client is still able to fight against this, but there's a pain. So like I said, anything maybe about a 4 above out of 10, we can actually suggest there might be a pain. This is indicative usually of tendinopathy or impingement. So what we might have to do to remedy this is acute rest, making sure that the client is able to perform full ranges of motion without any pain. There might actually have to be anti-inflammatory injections or medications to actually reduce that impingement or tendinopathy. The third outcome is where there could actually be pain and weakness as well. So this is going to be more indicative of a complete or partial tear of the supraspinatus. Now, to remedy this, it might actually have to take surgery. So the surgery could actually be open or arthroscopic. So that actually depends on the severity as well of this tear. So it could be complete or partial. The fourth outcome could be where there's actually no pain at all in this position, but there's a weakness. So my client's unable to actually fight against this. This is going to be more linked with like a neurogenic problem. So probably the brachial plexus and C5 palsy could be actual issues regarding the nervous system being able to fight against that and actually have the strength capabilities of fighting against the resistance offered. So there's likely to be a brachial plexus problem, which often you'll see with people that suffer from cervical injuries, things like motorbike accidents, or maybe complications with surgery or anything like that. So if you're actually training somebody and you're watching this video, what you need to make sure that happens a lot, or you need to take backwards a lot, is a lot of overhead movements. Now normally I have a lot of male clients that will come to me that like to do their bench pressing, their pull downs, their pull ups, their shoulder presses, working these big muscles here. So sometimes you need to make sure that you're really taking care of yourself. Take those deload wigs, take a step backward. You need to make sure the teres minor, infraspinatus and the subscapularis are also not impinged, but you're most likely to see it on this superior muscle. So this is really the reason why I want to talk about the supraspinatus. In future videos, I'm going to look at the other rotator cuff muscles, so I just want to thank Alexi and thank you for watching, and I'll see you in the next video.